Hey everyone, what's up? This is Dr. Charlie Johnson, physical therapist, and this video is going to be perfect for you if you have buttock pain in one side and or both sides, and it may even radiate into the legs. You've likely been told you have piriformis syndrome and or sciatica, and sitting or lying down or putting pressure on your buttocks is super sore. It's really sensitive and you have trouble doing those things. If that's you, I'm going to share with you a case of a gentleman you can really relate to. His name is B, and for the past several years, he's been dealing with these types of symptoms and been told he has these things, but despite the MRIs, despite all the different tests, nobody's been able to connect the dots for him, and he hasn't been able to find a solution. That is until we started working together. So I'm going to break down his case, watch, learn, pull out the nuggets, and ask yourself, how can I take what Dr. Charlie is saying, is teaching, the concepts, the principles, the way he's thinking, and apply it to my own case? And if at any point during this case review conversation, you're interested in determining the most likely source of your back, butt, or sciatica problems for free, go ahead and download my Better Than an MRI DIY diagnostic guide. You can click the link above and or check the comments and description. All right, so let's dive into it. Buttock pain caused by the brain. Believe it or not, very, very common. You can see here, just so you know who I am. Again, Dr. Charlie Johnson, orthopedic board specialized, residency trained, and only help people with back, butt, or sciatica problems. Just mean I'm highly specialized in this area, so I share that to know that who am I? What do I do? I'm in the trenches working with people like you every single day. Now, as we go throughout this case, as I work with people all around the world, one of the first things I ask people to do is that they submit a detailed case review. It gives me all the details I need to confirm if I can help, how I can help. And so I've laid everything out here for you. B's case review, we're going to review that briefly, go really in depth. We're going to review the results of the self-movement exam. And again, you can follow along with this. We're going to summarize the information, how we measure things when we work with folks, and then we're going to crack the case. We're going to talk about the problem. We're going to talk about the solution. There's an actual bonus video, if you will, of me working with him. And again, this is my Better Than an MRI DIY diagnostic guide. There's an entire framework for figuring out the most likely source of your symptoms if your pain is due to an issue in the tissue, a problem with the structural body. All right, so let's dive into it and work through it step by step. All right, so starting things off with the case review. So you can see here what we call a pain body diagram. This is exactly where Brian describes the symptoms. Buttock pain centrally radiates into the top of the thighs and the back side, and now has developed some left heel pain for unknown reason. This is the case review that he submitted. So male in his 60s, both sides of the butt low, sitting too long, radiates to the back of the legs, left heel's been sore, 16 plus months. What originally caused your pain? Well, 2018, there was a long car ride that developed, and he thought it was piriformis syndrome, seemed to treat it, went away, but it would come and go, which tells you they didn't really solve the problem until March of 2023, and then it's been stuck ever since. So quite a long time. Tried PT, chiropractor, x-rays, multiple MRIs, hip, lower back, nerve tests. Final diagnosis was this cutaneous femoral nerve entrapment. And so they sort of ruled out piriformis syndrome, but they were still wrong. You can get all the tests and all the pictures you want. Don't treat the picture, treat the person. What do they believe to be the source of your pain? Unknown, but sitting is what hurts. Movement, not necessarily the issue. These are important indicators that we're going to talk about and help you understand why this is happening. PT just does simple glides and nerve flossing. They think it's a nerve issue, and it is a nerve issue, but not the nerve that they've been led to believe. Pain is consistent day to day. Pain is not delayed. It occurs immediately in the moment when he's sitting or when he's lying down and putting pressure on that area. Does pain move or shift around? Nope, it's always in the same spot. Does stress influence your level of pain? Yes, it does. Being distracted, does that impact pain? No. Any significant life event that occurred, 2018, long stressful car ride, 2023, next day after golfing. Not really, but maybe a little bit of stress there. Please list below all the things that make you feel worse. Sitting, super yucky. Riding bike, yucky. Sleeping on back, again, the pressure tends to generate some tingling and funkiness in the butt and in the legs. List below all things that make you feel better. Movement in general is yummy. So movement feels safe for the most part. Walking, stairs, all that stuff, standing, no issue. Sleeping, all fine. But none of the motions, we'll go through here in a moment, none of these motions make him feel worse. Very common. About 50% of the people we work with have no yucky motions. They say, well, how can you help me? Well, let's talk about how we can help. Try walking your heels. We test some strength. You can do that on your toes. Test for some nerve stuff in the lower body. Yes, you can do that. No loss of bowel or bladder. No history of cancer. Anything else? Tear of his ACL. Some arthritis in the left hip. Right shoulder pinchiness. That's about it. What else have you tried? Just diagnosis and obviously all the other things. PT, chiro, all that stuff with little result. Sitting is the problem. I know I'm going to have issues with any event I go to, and the situation may never be resolved. That's really a stinky place to be. If you're watching this and you think it'll never be resolved, do you believe you can get better? That's the number one thing. And clearly, if you're watching this, you haven't given up. So stick around and let's talk about a different solution. Where do you feel most stuck? I did retire in January, so more sedentary lifestyle, but sitting is the issue. I want to be able to eliminate the pain. Sitting. Anything else? I have great flexibility. I golf and stretch and generally no issues. When standing, no pain, but I can press and push on the area of his lower buttock and there's soreness. When I sit, pain and discomfort really starts to radiate. All right, so now almost have the complete picture here. I asked people go through 6 different motions, essentially on both sides of the body. So 12 to 13 different motions in a self-movement exam. I believe that you watching this know better what you're feeling when you do these things than I do. All right, so I want to give you back the power. I said, hey, twist your trunk right, twist your trunk left. Pull your right knee to chest, your left knee to chest, your figure 4, like you're putting on your socks or shoes. Right side, left side, leg raises, forward bend, center, right, left, back bend, center, right, left, and anything else that this person might want to add or you might want to add. You could include that in a self-movement exam. And as we go through, if we summarize, again, you can't manage what you don't measure. So we have folks measure all this stuff so we can tell precisely how well they're doing, where they're stuck, and where a good baseline is. So you can see here, this is the self-movement exam. We have people rate things. If there's no pain, it's yummy. If there's some yuckiness, well, is it either low, medium, or high? Low, you can see there's numbers there, medium, high, and we have people score these things. So twists, knee to chest, figure 4 is very, very low. In fact, sort of admitted later that he wasn't really too confident in those numbers. He was just trying to find something, because I got to find some motion that's painful, Charlie, so you can help me. Not so fast. Everything else pretty much yummy. And then, he doesn't really list any positions here or any other motions, just the absence of motion, sitting, riding in the car, lying on the back. These are all positional issues. So then he botches the process a little bit when I ask for top 3 yucky motions, and he doesn't put any yucky motions. He puts positions because he can't find any. And so positions are the absence of motion. So basically, you could say all motions are yummy. There are no yucky motions. But you can see here, filled them in with some basically what I would call pain triggers. He just basically repeated them here. Sitting, driving, biking, sitting, riding, lying on the back. All right, so very similar stuff here. So even though he goofed it up a little bit, you get the concept. He was pulling for straws. He could not find a clear and consistent motion that made his symptoms worse. So he thought, you know what? I've got to put something. I paid for this process to work with Charlie. I've got to put something, because otherwise, how is he going to help? Well, he comes to find very quickly what the cause of his pain is and what he needs to do. You can see here, really cool, because we measure things. 33% better if you do the change between knee scores and knee scores just in a 2-week time frame after many, many years. Stuff is really powerful, and you can start to see quick results. So we measure things. Then we have all the info we need to start cracking the case. So we've got 2 things within cracking the case. We've got the problem that we want to figure out, and then we've got solution. So let's talk about the problem. Whenever somebody reaches out to us and is interested in potentially working with us, again, they submit a detailed case review. And the first thing we start to do is decode this. So I review all cases personally. First thing I want to do to make sure that they're reaching out to the right person is to rule out anything that's big, ugly, scary. We clear the bus, big, ugly, scary. All right. And the big things we're worried about would be like cancer, fracture, infection. In this case, maybe some vascular stuff and stress reactions, just things that maybe we're not going to be best fit to help at the moment. So obviously the big, ugly, scary thing for most people is cancer. Now, luckily, again, 0.6, so what is that? 6 out of 1,000 people who have back butt or sided problems will have cancer as the cause of their symptoms. But, he's had x-rays, he had MRIs, so again, they would have picked something up. I believe also blood work, they would have seen something, so I'm not too concerned about that, but I always do my due diligence. And what we do to rule these things out is we base our questions in the case review and our screening procedures on the evidence, on the research. So yes, even though I'm not an x-ray machine or an MRI machine, and I'm just a PT, we're very well trained in diagnostics. So there are test item clusters or groups of signs and symptoms that make us think, you know what, this person might have cancer or a tumor as the cause of their back butt or sciatic issue. We should refer them out. So age greater than 50 is greater than 50. Previous history, cancer, no. Unexplained weight loss, no. Failure to respond to conservative treatment, I would probably say yes, but what type of conservative treatment? Doing a sheet of exercises, that is not good quality conservative treatment. It's a really good screening cluster, essentially if he had all 4, or even if he just had the previous history of cancer. So you can see here, if previous history of cancer or 3 out of 4, I really go for generally all 4, but previous history of cancer is what I'm looking for, then we would refer out. But he's already had x-ray and I think even some lab work. So we can say with a high degree of confidence, not that. Now we look, okay, is there some fracture that happened? Well, there wasn't really a mechanism of injury. So there was no trauma. He's not female, but just anybody could have a fracture. But that being said, no trauma, not greater than 70, but getting closer, male, and no history of prolonged corticosteroid use and or some other things that might weaken bone health. So smoking, excessive drinking, things like that. And so we're not going to rule him out as we do not have a high suspicion of that. Not a female, but males can get this as well. Not in his super active years. Mentioned he was very, very sedentary. No menstrual cycle. No reduced bone mineral density that I'm aware of. No eating disorder. These are things we look for in generally a younger, more active population. So we're going to rule that out pretty quickly. Peripheral arterial disease, yeah, might be something to consider with someone who's in their 50s, 60s, 70s and having both-sided buttock pain. Could you have some issue in the aorta or in the vessels that lead to that area and they're not getting the blood supply they need, so they're causing pain? But here's the difference. Generally, it's exertional. Right? So when the vascular system has to work, that's when the symptoms would come on more. Versus he's just sitting there when his heart is not having to work at all. Right? So he is greater than 50, but it's positional. It's not exertional. He doesn't get when he's walking, when he's standing, when he's really moving about. He gets it when he's stationary. He may have a cardiovascular history, but again, given where he's at and all that he presents with, there is very little risk of that. So boom, we just ruled out big, ugly, scary. Now, he's on the right bus, he's in the right place, and we can likely help him. But what is the real source? Is it of the body? And we need to zoom out and start looking at all these different things. Is it a disc problem? Is it a facet joint problem? Is it an SI joint problem, a piriformis syndrome problem, a hip problem? Any of these things, or is it not? And so what I've done here is I've taken his specific evidence list and just copied and pasted it so that you can see it. And what we do is we ask people a series of questions. We have 13 different questions that we ask. And these questions help us differentiate between, is it of the mind, in which case his symptoms were due to a perceived danger or dis-ease psychologically within the nervous system, or is it due to some type of damage? They've done x-rays, they've done MRIs. He's coming into the platform of the program saying, I have piriformis syndrome, it's sciatica, but is it really? And if so, why has nothing worked? And so first things first, are you unsure as to why your pain began? Problems of the body generally have a clear known reason as to why they begin. Problems of the mind, they may have just started for no clear reason. So to this first question, he says, no, I am sure as to what caused it, a fall in 2018. But then he said the first time I experienced pain was on a 6-hour car ride. I'm not sure how he fell while he was in the car. This is starting to sound like what we call perceived injury. He's trying to pull for straws. To visit his daughter at college, I always drive. Pain slowly came on and shifted. He was shifting around a seat. Driving back home, the pain got much worse. Treated with PT for Piriformis syndrome. Eventually, it went away. Slight pain came and went after spring 2020. Came back with a vengeance after golf in 2023. Golfed on Saturday. The pain came the next day. No injury was experienced. So you can see there's sort of a mixed bag here. He said, no, I am clear as to what caused it. But now it's like, well, I'm not really clear what caused it. So really, that's even probably a yes. I'm unclear as to what caused it. But that's fine. We'll give him the benefit of the doubt. Is your pain chronic? Yes, since March 2023, and I would even argue since 2018. Generally, what we see is that problems of the body heal within a 3 to 6 month timeline in most cases. So if you're dealing with pain for more than 6 months, then that may suggest the symptoms are not as much of the body as you've been led to believe. Did your pain begin during or around a time of fight or flight? It's always racing. I stressed about a lot of things. I was frustrated. I wasn't golfing very well. Is your pain inconsistent? Do you have some good days or bad days? Depends on how long I sit. It's about avoidance now. If I'm walking, stairs, golfing, I'm good. It improves after sleeping. Although if I press on the area, I can feel the sore areas. So he's telling me, Charlie, when I push on this area of my butt, it's very sensitive. It's tender. Left side is worse than the right. Sitting, gets pins and needles, starts in the butt and moves all the way down. Also, again, he's starting to feel some stuff in the feet. Does stress trigger your pain? I don't believe so. My question would be, if stress is the cause, wouldn't I feel the pain discomfort while standing? Interesting. Do you experience relief of your pain with distraction? Yes. If at a social event when I'm sitting, takes my mind off pain. So is it really there? Do you have pain or symptoms or problems in other areas of the body? My wrists have been sore, consistent with this wrist diagnosis, decurve veins. Steroid injections worked for a while, but the pain's back. Other pains, arthritis, impingement, pain in his heel due to overuse. At least that's what he believes at the moment. Does your pain shift, spread, or move around? Symptoms that are of the physical body generally don't. If you have a tear in this shoulder, it generally doesn't jump to the other shoulder. It stays somewhere in the shoulder. Pain seems to be consistent, both sides of butt, same area. Sit too long, pain radiates down the legs and tightens in the feet. This may have been able to be a no, but either way, it won't change things too much. Do you experience delayed onset of symptoms? You already did. Sitting, the pain comes on almost right away. Very consistent. Golfing, walking, or doing stairs, no pain while doing these activities. Have you been given many or no clear diagnosis? Had it all. X-rays, MRI of the low back, hips, 2 EMGs, multiple treatments of PT, nothing. Are you a high-pressure perfectionist, people pleaser, type A, good student, get her done type of personality? Yes, this is me. Just recognize you're watching this. There's no problem with that. I would fall into that category. You can tell how fast I talk, right? But that tends to elevate our state and just kind of predisposes to being in a little bit more of a fight or flight mode just naturally, sensitizes the nervous system. Is it hard to identify yuck emotions that clearly and consistently reproduce your pain? And he said no, but really, as you'll see here, it's really yes, because he just told us no emotions bother him. So you can see how people sort of fill this out maybe to fit their narrative, or again, because he's a little bit confused. This is what confuses me. I do not have pain while in any motion. I feel no pain while in motion, only when sitting. The longer I sit, the worse it gets, only when sitting. Stand and walk, it'll go away. Also opposite of a video that we showed him. If this is in reference to PT motions, those didn't work either, all right? But he can press down, again, physically in areas of the butt and causes symptoms. So he does have a hard time. That should be a yes, identifying clear yuck emotions. Has there been a lack of response to physical treatment? Yes, tried all sorts of PT, glides, flossing, nothing works. My last couple of visits to PT to the therapist, we agreed to stop the motions, and basically this PT told him to go into avoidance, which will actually make him worse, as you'll learn here shortly, to calm everything down. They don't even know what they're trying to calm down. No relief. Now, look, this is what's interesting. The cool thing about this evidence list is that we look at things objectively. We don't go based off what we think or feel, or even what you think or feel. You just fill this out. You don't try to josh it. You look at the data versus the emotion of this. When people are in pain, they tend to go insane. Have a place to record it. You've got to start tracking things. If you do not track stuff, you will be lost. So we have people go through this process, and ding, 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 because diagnostics occur in probabilities, this gives us a readout. It says, hey, 69% probability, so vast majority probability. Symptoms are more centrally driven by the mind than of the body. So yeah, could we, and he's already gone down this path, could we go down the path of trying to go through an evaluation to determine, is it a disc problem, is it this, is it that? This is the way a lot of people would have went, and it may have made sense. About 50% of the people we work with have symptoms of the brain versus the other 50% of the body. Right? So lots of people we work with have, say, SI joint problems or disc problems. Maybe you just bent over and injured yourself, or Piriformis Syndrome problems or hip problems, whatever. But in this case, it doesn't make sense, because even just based off the story, based off the case review, based off everything else that he's describing, it's not consistent with a structural problem. It's non-structural in origin, almost without a doubt. And so that is the problem. That is the problem. And so now what do we do to solve it? Now that we've weeded that out and we've ruled out the big, ugly scaries, obviously, now there's got to be a solution. And so I'm going to share with you a bonus video of me chatting through a portion of the solution for somebody, maybe yourself, with this issue. And in B's case, we combined this approach. We educated him and gave him knowledge, which is potential power, to start to help him see the actual root cause of his symptoms. And then obviously we're coaching him through some of the steps to get back to sitting with more comfort. Now, this is part of a much larger process. We'll talk about the main goal of the process, but step one, you've got to optimize the healing environment mentally and physically. Physically, any habits, routines, things like that, that maybe you just don't know are showing up in your life that could be keeping you from healing and picking the scab. Mentally, any fears, worries, beliefs, concerns. Obviously, we shattered many beliefs for Brian going through this process with him. Self-assessment, scan the body, teach people how to self-assess like we talked about. I shared it with you there. So you can start to identify immediately a baseline and what your body prefers versus what it doesn't. Third step, mind and movement is medicine. You'll see some of the mind is medicine in the video above, but movement is medicine is also something that we've had a discussion with B about as it relates to finding motions that feel safe and immediately improve his movement experience. So the goal is never to do a sheet of exercises. The more you do, the more confused you'll be. The goal is to do less and get better faster. So we help him find the one motion he needs to do to aid in his recovery. And then finally, we need to get him back to life, sitting, driving, doing all the great stuff he wants to do now. And the cool thing is, because we're teaching him this process, this is what we do for everybody we work with, he's self-sustainable. He doesn't need to go back into the diagnostic rabbit hole or the healthcare rabbit hole, as I call it, seeing lots of different people, getting all kinds of different opinions, when all along it was within himself to heal. Okay, so what is the goal, by the way, of the treatment? To change his reaction to pain, not change the pain himself. Based off our evidence list, we don't have any, when I say any, we have very little evidence to suggest that his pain is of the physical body, something going on here. And by the way, his images, they do show things wrong, but they have led him to bark up the wrong tree. So none of that stuff's worked. And so instead of changing the pain and the physical structure per se and making the goal fixing something damaged in his body, well, we have more evidence to say, hey, if we know pain is a danger signal, then how can we eliminate the danger signals associated with the experience of pain? All right. So right now he's in a state of danger. Every time I sit, I feel symptoms. Every time I sit, I feel symptoms. Every time I sit, I feel unsafe and I feel symptoms. We need to restore safety to his sensitive nervous system, and we do that in several ways. Recognize if you're watching this right now, you're probably stuck in a negative feedback loop. This is the pain experience. There's nothing wrong with you. It means you have a very good brain and you're actually functioning very optimally, most likely. All right. And it starts, maybe you had a fall like B. Maybe you went golfing and you twisted your back, something like that. And movement and or life, positions in life even, start to hurt. Well, then what does that tell the brain? Hey, something's wrong. Fear, worry, concern starts to put you in a state of more danger, fight or flight. So the more fearful you are of things, well, what did B say? Well, I started to just avoid sitting. And by the way, my PT told me to avoid sitting. And I started to avoid golf. And I started to avoid all these different things because I was fearful. And the more I avoid things, the more fearful I become. And the more I train that reaction. And then the more sitting hurts. And the more fearful I am of it, etc. And so pain is an experience of both the brain and the body, designed to protect you from some perceived or actual of the body threat or danger. It could be brain or body. We help you figure it out and walk you step by step. And so you can start with any place here. If that is the pain experience, how do we flip it? Well, it's possible we could teach you to move in ways that feel safe and immediately improve your movement experience, immediately help you out versus just hoping and praying. And that gives you more confidence. Say, wow, maybe I am okay. Maybe I can do this, and hurt does not equal harm. And let me move more. In the case of B, let me sit more. And well, I'm okay. I feel more safe. Sitting becomes easier, so on and so forth. So just recognize that there is a bit of a process to the solution. One last little thing is, a lot of people would look at this story and they'd say, but Dr. Charlie, when I press on my butt cheek, that really hurts. And so that means that that is a problem in my butt cheek because when I push it, it hurts. Well, your ability to sense anything is really driven by the sensory cortex, which is where, not in your butt per se, it's in your brain. And it's possible we could cut your butt cheek off and you could still feel pain in a butt cheek, which is not actually there. It's called phantom limb pain. And so just because you can push on something or feel something in the body doesn't mean it's physical. So be careful of just taking one little clue. Oh, well, I know I fell and that's the cause of my pain. And then just throwing your body in jail as the cause of your symptoms. You've got to look at the entire picture. And, you want to find someone who understands not only the best of orthopedics. I have my board specialty in orthopedics, but also the best of psychology and the role that the mind or the brain plays on symptoms. And how can you differentiate the two? Well, this is a process to help you start to do that. All right. So that is all I got. Hopefully this was helpful and you can see that no matter where you feel symptoms, could be in one butt cheek. It could be both butt cheeks. It could be just in the butt and the calf. It could be in your mid back. It doesn't really matter. the first step is that we need to go through this process of connecting the dots. We need to rule big, ugly, scary things out. We need to identify brain or body. Within the body, what is it? Is it a disc problem? Is it an SI joint problem? Is it a hamstring problem? All that stuff. We could do that all, and we do it very, very systematic, step-by-step process. And then you'll see that we use a framework for treatment that just works. So process works if you work it. If at any point, by the way, you're interested in potentially working with me, go ahead, click the link below to apply to submit your case. Just like B did, I'll review your case personally to see if we can help, how we can help, and what that might look like.
I was searching for, yuckies, but, it's sitting and lying on my back. It's just the pressure on the butt area.
Yep, I get it.
6 tests of what possibly are, yucky, and going from there. Those are all yummy to me. I don't sit very long right now because I'm trying avoidance because I don't want to bring it on.
So yeah, so what I hear, big picture, all the motions are pretty much yummy, right? Which makes it difficult to test, treat, retest, and go hunting for motions because you're not even sure you trust that your yucky motions are all that yucky.
Yeah, I know.
That's okay. But you've got all yummy motions, but sitting is a problem.
Yeah, that pressure, that contact.
I get it. By the way, that's another clue. It's another clue that your symptoms are more centrally driven than they are structural of the body. Let's just say I said to you, hey, my shoulder hurts really bad when I'm swimming, Brian. All right. Ow, ow, ow. But let's just say you come to me or I come to you and you're the PT and you say, can you move your arm like this? Yep. Can you move your arm like this? Yep. Can you move your arm like this? Yep. Can you move it like this? Yep. Can you move back here? Yep. Can you do this? Can you do? I can do anything I want with this arm, but when I go swimming, I just can't swim. What would you say?
I'd probably say, what's wrong with me? My first question.
Yeah, very good.
And why can't we find it?
Right. We can't find it because the mechanical system is fine. And we only are viewing things through a mechanical lens.
Yeah.
We're not considering that, there could be something else that could generate pain in the shoulder. A brain. And so this is why, you go to ortho doc and you get all this tests done. And they say, I don't really know. Nothing really matches up. Or they tell you everything's wrong with you because they just are trying to give you something. And then you go down the rabbit hole of treating it and it doesn't work because they didn't use the lack of consistency in the orthopedic exam and the absence of a clear pattern to inform the fact that there actually is a very clear pattern. The absence of the pattern, which means that it's probably centrally driven by the mind. All right. And so a good orthopedic person can understand not only the orthopedic side, but then knows that the lack of consistency in a clear clinical exam is suggestive of or diagnostic of other things. In this case, more central sensitization. So the fact that you do not have clear, consistent yucky motions, or you're not so confident about them, let's just put it like that, but you have trouble driving. I can move my leg like this, Charlie, and like this. I can do everything required of driving independently in motion form, but I just can't sit or drive.
Yeah.
Centrally driven problem. No question. When you take that too, maybe you just don't take that one clue. Well, that's a strong clue. But when you take that clue and you look at all the other pieces of the puzzle and you look at all the evidence, so to speak, right? You have all the different clues on the table, then it really starts to become very obvious. I have no evidence to believe that when you sit your butt on a chair, that something's being pinched or that there's some damage being done. Have you trained yourself and do you have a belief that that's happening? Sure. But it is possible that the belief and the learned or conditioned association between sitting and symptoms is the reason that sitting and symptoms persist when you sit. Not that sitting is actually doing anything to you. Now, that sounds crazy because when I say not doing anything to you, it doesn't mean you're making this up. It's not doing anything to you physically other than what normal sitting would do. But it is doing something to your brain where that neural pathway has been grooved. Sitting, pain, sitting, pain, sitting, pain. Very common.
Yeah.
All right. Are you shocked by that answer or no?
No, after going through the program, and I got to looking outside of the diagnostic process because I had essentially exhausted it. We were already down to eliminating everything and say, well, let's cool down. Let's stop aggravating it.
Yeah.
So I had done all the physical therapy. I've had 2 MRIs, blah, blah, blah. I've been deep into it.
I get it. Yep.
And the last discussion I had with my physical therapist is said, well, he says, stay healthy and active, but he says maybe it's just time to let the body relax.
Yep.
And okay, I started to do that, and I'm
Right,
like,
but then what do I do next?
yeah, I'm stuck.
I'm keeping this very simple for you. When you sit, you're walking. You mentioned you were walking earlier, and you sit on a picnic bench or a bench or something like that, right?
Yeah.
You start to notice symptoms. Is that accurate?
Not right now, not that bad. Yeah, just a
Good.
little bit. It's gotten a
Okay.
lot better.
Good. And then when you stand up and you start walking again, does it simmer down?
Oh, it's gone.
Good. Okay. So if I were you, I'd be sitting as much as possible at this
Okay.
point. At this point. So here's the reason. When you're sitting or when you're walking, you're fine, right? And then you sit down and you start to notice the symptoms come on, but they're more tolerable than they were. And so if they're more tolerable than they were, and as soon as you remove the stimulus, we'll call it sitting, and you stand and the symptoms are pretty much gone immediately, I have no reason to believe that either physically, let's just say, oh my gosh, Charlie, I still believe there's a small chance that it could be something physical. Well, okay, but you're not inflaming anything because inflammation is a chemical response, and you will notice lasting symptoms for hours, for days. You won't be able to sleep. If you get up, if I put pressure on my finger right now, it hurts. When I let go, it's gone. I didn't inflame my finger when I was squeezing it. I was mechanically causing, it was like a mechanically induced pain or sensitivity, not a chemically induced. Now, if I smack my finger too hard, then it'll be throbbing later and it'll be bloody and it'll, I'll wake up in the middle of the night and I'll be like, and I'll have to put it above my head or, or do something like, I'll shake it, right? That is the difference between like a mechanical pressure. When I put pressure on it, feels a little yucky. Now it's gone. I'm not going to tell you to shy away from that because I have no evidence that you're physically damaging anything. Pain equals damage, structural problem, or that if psychological, that you're setting off the bells and whistles so much to the central nervous system that you're re-traumatizing yourself. If you have no pain, you can't change your reaction to no pain. Red light, yellow light, green light. If red light, symptoms are so yucky, they're a 70, 80, 90, something like that. When you get up, they're all flared up and things are really ticked off. I'm not asking you to sit to that extent of symptoms. If I were you, what I would do is I would sit, not no pain, not 60, 70, 80, 90, red light pain, yellow light, 10, 20, 30, 40, tolerable symptoms. So long as the symptoms stay within that middle range. And when you get up, it goes away immediately. You stand up, you say, oh, it's pretty much gone. I'd say, sit your butt back down, Brian.
Okay.
In the nicest of ways, obviously, right? But I would be sitting down again, bringing them on. Stand up. Okay, now it's getting point. I don't know. Stand up. It's fine. Let them go away. Lift up the bed again and look at the monsters. Okay?
Yeah.
Feel nervous. Shut it. Lift it up again. They're behind glass. They can't get to you. What gets people into this problem is that there's such a fight or flight reaction or response to it. Images, this, that, different opinions, stress, life, all that stuff. And when I sit, I get symptoms. And when I sit, I get symptoms. And this becomes so deeply grooved because we sit so often throughout the day that we just associate sitting with pain. And so now, the more often you can sit, knowing now what you know, that's weird. My brain's making a mistake. Charlie feels pretty confident about what he's saying. Should I believe him? I don't know. Well, maybe there's something there, right? And so you'll start to look at this with a little bit more curiosity. And the more you can sit and start to reappraise that sitting as something that's not damaging, and you can start to kind of react in a completely different way, the more opportunity you have to groove that neural pathway. You can change the neural circuitry such that every time you feel symptoms when you're sitting, so long as it's tolerable, and you practice showing it up and viewing it through a lens of safety versus fear and reaction, that's an opportunity. That's one rep. That 10 minutes later, that's another rep. 5 minutes, that's another rep. The quicker you can put in reps, generally, the quicker and the better the opportunity you have to sort of reprogram your reaction to it. And because the physical symptoms are the result or the consequence of psychological dis-ease or reaction, fear, worry, concern, avoidance, threat, danger, as soon as you get rid of this reaction, this goes away. Poof, gone. Kind of get it?
Okay. Yep. Yep.
So then you make the action the goal of practicing that, not the outcome of getting rid of it. It will go away. There's zero question. Pain is a sensation plus danger signal. It's attached. As soon as you get rid of the danger response, the symptoms will go away.
Yeah, I was doing a lot of avoidance because I wanted to not get into the
Well, you were
7,
told to
8,
avoid
9,
it.
10. Yeah.
Yeah, I mean,
Oh,
hey, let's let your body chill. Let's just kind of not try to do that. But avoidance taken too far will just make you worse, as you saw. You'll become deconditioned physically. And then that which you avoid, you teach your brain that, well, I'm avoiding that for a reason. Because clearly I'm afraid, worried, concerned, or whatever by it. And you train your brain even more. And so let me know in the comments, was this helpful? Were you able to pull out some nuggets? Was it useful to see the problem solving sort of logic and the way that we go about helping people so you can start to help yourself and not continue down the pathway of getting more x-rays, MRIs, seeing generalists who aren't exactly sure what's going on. So let me know your thoughts in the comments. Thanks so much for watching.